All right, this briefing is a high-density summary of the 2026 Neurocritical Care Society Guideline on Neuroprognostication in Critically Ill Adults with Status Epilepticus. The goal here is simple: distill the core recommendations so you can apply them directly in your clinical decision-making.
So this really gets to the heart of a major clinical challenge, doesn't it? How reliable are our prognostic tools in status epilepticus? We have these high-stakes conversations all the time, and this guideline is a direct attempt to tackle the uncertainty we all grapple with.
And the core imperative here is crystal clear. Our prognostic assessments are what drive decisions about withdrawing life-sustaining therapy. The danger, and it's a big one, is that if we're using unreliable predictors, we risk creating a self-fulfilling prophecy. We predict about outcome, that leads to withdrawal of care, and, well, that confirms the poor outcome. This guideline confronts that risk head-on.
Okay, here's our roadmap. We'll start with the good practice statements, which are really the core principles. Then we'll systematically tear down the evidence for individual predictors and the prediction models. We'll finish up with a summary of the guideline and a look at where the research needs to go next. So let's start with the foundational principles. Now pay close attention here, because this is crucial. These 6 good practice statements are the only strong recommendations in the entire guideline. These are the consensus on what we should all be doing right now. The first 3 really boil down to communication and managing expectations. First up, you've got to establish patient-specific goals of care. This isn't just about stopping the seizures, it's about what an acceptable outcome looks like for that specific patient. Then, for your refractory or super-refractory cases, you have to be upfront with surrogates. Counsel them that this could mean a prolonged coma and life support for days, even months. But, and this is just as critical, you also have to tell them that long-term recovery back to baseline is feasible, even in these tough cases. Though, of course, complications can get in the way. Okay, the next 3 are all about clinical diligence. When you do have an established etiology, you need to use validated predictors for that specific disease. For example, if it's a post-arrest patient, use the established predictors for anoxic brain injury. Next, and this is basic but vital, don't even attempt neuroprognostication until you've cleared confounders like sedation or a toxic metabolic encephalopathy. And finally, if you're dealing with status of an unclear etiology, just wait. Defer prognostication until the diagnostic workup is done. The diagnosis itself is going to be your biggest guide. All right, let's move on to the individual predictors and see how they hold up for predicting in-hospital mortality. The guideline panel really dug into the data behind all the variables we tend to rely on in our daily practice. And frankly, the conclusion from their systematic review is, well, it's pretty brutal. Just look at this. Every single individual predictor they looked at, age, comorbidities, etiology, duration, even refractoriness, every single one was found to be not a reliable predictor. And look at the quality of evidence, low or very low across the board. This is really a central take-home message of the entire guideline.
So let's break this down, starting with age. The guideline gives a weak recommendation against using it as a reliable predictor. Why? Well, for one, the data is all over the place. The association with mortality is just inconsistent. But more importantly, from a clinical standpoint, older age doesn't automatically mean a more severe cause of status. You know this from experience. A young patient with encephalitis can have a far worse prognosis than an elderly patient whose status is from something simple like medication noncompliance.
Okay, so what about etiology? Surely that matters, right? Well, it turns out that even trying to categorize the cause as acute symptomatic or potentially fatal is unreliable, and it's based on very low-quality evidence. Part of the problem is that the definitions are a mess and inconsistent in the literature. But the key point is this. The panel found no single diagnosis that carries a universally poor prognosis. Not even anoxic brain injury after a cardiac arrest. We've all seen reports of good functional outcomes in those cases.
We all worry about the duration of status epilepticus. But again, the guideline says it's not a reliable predictor. There are a couple of reasons. Practically, it's just hard to measure accurately. And methodologically, you have that huge risk of the self-fulfilling prophecy bias we talked about. And the real kicker, there are plenty of reports of excellent outcomes even after very, very prolonged status. And what about treatment refractoriness when a patient progresses to RSE or SSE? Now, look, these states absolutely indicate how severe the disease is, but they are not reliable standalone predictors when you're trying to prognosticate for an individual patient. And the reason is the same one we keep coming back to, the overwhelming risk of that self-fulfilling prophecy, because we know that withdrawal of life-sustaining therapy is a huge driver of mortality in the SRSE population. So if individual predictors are unreliable, the logical next question is, what if we combine them? Let's look at the composite clinical prediction models. The guideline panel took a hard look at the three big ones: STES, MSTES, and EMC.
First up, the STS score. The bottom line from the guideline is a recommendation against using it as a reliable predictor. Its ability to discriminate is just moderate, with AUCs somewhere between 0.6 and 0.8. But here's the real problem. Its positive predictive value for mortality is only 20 to 40%. Think about that. That is a completely unacceptable level of inaccuracy when you're guiding decisions about life-sustaining therapy.
What about the modified STS, the MSTS, that adds in pre-morbid functional status? Well, it fares no better. The discriminatory power is basically the same as the original STS, with AUCs in that 0.6 to 0.75 range. It turns out that adding premorbid function just didn't improve the prediction of in-hospital mortality at all, which suggests it's really the acute illness severity that's driving things. And then there's the EMSC score. This one looked really promising at first. The development study reported an AUC of 0.9, but that incredible performance just wasn't reproduced in later validation studies. They found AUCs dropping down to the 0.69 to 0.86 range. And this is a classic story for prediction models, right? The failure to replicate in external cohorts is exactly why the panel ultimately recommends against using it as a reliable predictor. So after all that, where does this leave us? Let's synthesize these findings in a final summary and talk about the path forward for research. Okay, so to summarize the entire guideline, it's this. You've got 6 strong recommendations, and every single one of them is one of those procedural good practice statements. On the flip side, there are 13 weak recommendations, all of them arguing against using the clinical variables and prediction scores we've just discussed. The bottom line is absolutely unequivocal. Not a single predictor or model they evaluated was found to be reliable enough for neuroprognostication when you're making decisions about withdrawal of life-sustaining therapy. So given this pretty striking lack of reliable tools, the guideline lays out 4 clear imperatives for what we need to do next in terms of research. First, we have to standardize how we assess outcomes, looking at meaningful time points like 6 to 12 months, and we've got to include cognition and function, not just mortality. We also need a consensus on what data to collect. We need to build multi-center registries to get the numbers we need. And for God's sake, we need to use standardized definitions for everything: etiology, semiology, refractoriness, the whole thing.
I think it's best to conclude with this direct quote from the guideline itself, because it says it all. Our systematic review yielded a striking lack of reliable predictors to serve as the basis of prognostication while counseling surrogates of patients who may be dependent on life-sustaining therapy. That single sentence really underscores the current state of the evidence. It's a call for a new standard of clinical humility and a clear mandate for rigorous collaborative research going forward.